Welcome to CareTalk at Health 2019, our special interview series here at the Health Innovation Conference.
Extremely special.
Extremely, here in Las Vegas. It's so special that today we have Dr. Ezekiel Emmanuel, who's a professor at the University of Pennsylvania, among many other things, and also known as one of the architects, or the architect, of Obamacare.
Yeah, don't overstate
How's
it.
that house holding up? Steve? I mean, what's your assessment of the ACA? It's gotten beaten up a little bit from the main stage.
It's better than anyone had any right to expect. Just so let's go down the line. First of all, on coverage, it got 22 million people covered despite multiple attempts at sabotage. I mean, the Republicans have tried to repeal it more than 60 times. They did repeal the mandate. They didn't roll out Medicaid in all these states, and yet we have 22 million people with coverage. And I might say, more importantly, and less well known actually to most people, is the fact that there are 6 states, and I think the District of Columbia, where coverage is above 95%. So what it shows you is on the platform of the ACA, we can get extremely high coverage in this country. What we need to do is get the other states to do what places like Massachusetts and the District of Columbia and Minnesota have done, and that would be we could get to 95% coverage with very small tweaks that, permanent reinsurance, a little boost for the subsidy that goes to people under 300% of the poverty line, extending the subsidy up.
Does it have to be done at the federal level? Because the politics
well, look, as I say, we've got 6 states that have done it. I think states that want to really expand coverage could follow it. On costs, we've seen a flattening of the costs on Medicare, a flattening of the costs on Medicaid. Private insurance, there was a flattening between 2013 and 2014. Maybe there's a little bit more depending on how you want to look at the data. My assessment is that drug prices, hospitals have really continued on the private side, and we have to intervene. There does have to be some federal legislation intervening on the drug side and hospital cost side. You could do state by state cost.
But it seems like on the drug side, everyone agrees there's a problem. Everyone agrees that something should happen. What's achievable right now to kind of break the back of what seems like an unsustainable cost increases?
Well, what I like to tell, I like this piece of information. The United States has 4.5% of the world's population. We have about 50% of the world's drug costs come in the United States. It's ridiculous. So what do we have to do? Well, there are 2 alternatives if you look around the world. One is this sort of reference pricing, look at what other countries are charging and say drug companies can't charge more than a basket of them or the lowest 3, or countries do it differently, but basically it's looking at other countries and pegging your price to them. The second is look at cost effectiveness. Those drugs that give you a better health benefit ought to be able to charge more. I think those are compatible, and I would like to see some combination, and not just for Medicare, but for the whole country, because those of us who have private insurance, we need relief from drug prices too. I think that is achievable.
Can we get that stuff
I do think that's
Trump?
achievable.
Can we get Trump to support it?
Forget it. That's not going to happen in the next year. Democrats aren't giving anything to Trump. Republicans aren't giving anything to Democrats, and we're going to be involved in impeachment, and that's just going to prevent any kind of legislation. So it's going to have to wait for 2021. But I do believe there is consensus, and I do think you're going to see something move on drug prices, and the drug industry is not helping things. They have not generated an idea on how to control their prices, and
Are you shocked by that?
No, I'm not shocked by it, but I am actually shocked that they're not even playing defensive. They're not even trying to rein in the prices or have a proposal out there that's positive. They're just, let's get as much, they're frankly like the mortgage companies in the late 2000s. Let's get as much money as we can. We know the music's going to stop, but let's just you've got a $2 million drug. That tells you everything you need to know.
So on the hospital side, so you said about drugs, hospitals, you're talking about hospital prices. Most people aren't, and in fact, they're worried about hospitals closing. They're on thin margins. I mean, what do you say to that? They're going to cut the prices, and then we'll go out of business.
In cities where there's a lot of consolidation, prices have gone up. There's no evidence that they've been more efficient, and I think we're going to have to cap it. Rural areas where you are seeing, first of all, you've got tremendous underutilization. You've got 25-bed hospitals with 2 people in the hospital. Right. We need a completely different policy of linking those hospitals to urban hospitals that can do telemedicine and not try to save a full-service
But I
hospital.
thought the politics of that was people really feel like there's lack of access, and if that hospital closes, you
No,
actually
in the
lose all
rural
the
areas,
hospitals.
in the rural areas, you do need some kind of telemedicine, or you need access to emergency care and then evacuation. But in the urban areas, I do think there's been way too much consolidation, and we have to peg the price or cap the price related to the consolidation in the market. That would be a way that hospitals would stop consolidating and we retain competition. And I think that's important for price control.
How much of the $3.7 trillion of our healthcare economy is waste?
Depends how you define waste. Obviously, you know that.
Anything spent on this guy, for one thing, I'll start with that.
But
also, I thought you were going to stop using healthcare too. As you get closer to 75, how are you
I didn't say closer to. I said at 75. Boy, you can't even get the guys to quote you right. I would say, first of all, we've got unnecessary care. There's a lot of that. We've got inefficiently delivered care. I go around, and I'm sure you see this, you go around to the health systems or you go around to doctors, and they're still, how much revenue? Revenue is the wrong measure. You need to talk about margin, and once you do margin, you look at efficiency. But why don't they look at efficiency? Because they can raise prices. So it's easier to raise prices than to try to work hard and become more efficient. We have to incentivize that efficiency. And then there's, lots of things we shouldn't be doing. We need administrative simplification to get rid of and reduce the administrative costs, which, some people measure at $250 billion per year. Even if you got 40% of that or a third of that, that's serious money. So I think that's a combination of things where, is it $700 billion? Is it $1 trillion? There's a lot of waste that we could get out of the system that is serious money. So that's my view.
Now, so how do you, so it sounds like ACA is doing better than anybody could expect. You got a few tweaks to add to it. So what do you think of this Medicare for All debate? Is it a smart idea? Is it a smart policy, smart politics?
It's certainly not smart politics. I mean, I do agree that there's no way we're going to pass it. I think people forget we had, 250 some odd votes in the House when we passed the ACA, and we passed it by one vote. You got to be realistic about what you can achieve. We're not going to get Medicare for all. We're simply not going to get Medicare for all. And so we should be more realistic about what we should do. So from a political standpoint, I think, realism is important. And my own view is that's not a winning policy. So we should, talk about a winning policy. Improve the ACA, get serious about cost control, get serious about getting rid of some of this administrative weight, shift more doctors and more health systems to alternative payment models where they really are responsible for total cost of care. I think that's the direction we're going, and that will allow a lot of this innovation to take root.
So at CareCentrics, we want to shift more care out of hospitals and nursing homes to the home.
Totally.
I think that's where the future should be. But
I totally agree with that.
You've done a lot of studying of the ACA and what innovations have come out of it. What if you were to rank the most successful innovations around value-based care, cost control, better outcomes? What would you look for as great examples?
So first of all, I'm not sure we have had humongous success because I'm not sure we've had enough financial pressure for people to really whole hog go into alternative payment. First of all, on a system-wide basis, we have gotten a fairly good bump, especially on surgical procedures, from bundles. Mm-hmm. And so I would push much harder on bundles, and I think there are things we can do on that. Expand the bundles.
What's a bundle, just for folks who don't necessarily
Instead
understand
of paying for the hospital room, the surgical suite, the implant, the radiologist, the anesthesiologist, the surgeon, the post-acute care, you put it all in one. You say, this is the price. We're going to pay you $20,000 for that hip for before you operate to 90 days after you operate. And
so healthcare on a budget.
You're buying a car. Here's the whole shebang, rather than salami slicing each price. And we've seen that improve quality. We've seen costs come down because they shift post-acute care to the home. We've seen them shift and reduce costs in the hospital. So I think that's a winner, and we should push harder on that. I think who could be against that?
Like, what's the argument against bundles? Why haven't we rolled out more bundles?
I don't know. I don't think there's a good argument. I'd say the other thing, which is not well noticed, is none of the alternative payment models run by Medicare has been a failure, where failure would be it's cost more or it's led to worse quality. So at best, we can say we've done a lot of experiments and learned a lot, and it's been no harm to the system and some improvement. Well, that to me says, wow, let's push on what we've learned and improve it and keep improving it. And so I think doubling down on some of these alternative payment models. I also think that we've been a little hesitant and a little shy on how much pressure we put on, and also we've had the wrong timeline.
Docs and hospitals,
yeah,
you mean?
And we've had the wrong timeline. We know that fully shifting takes about 3 to 4 years, and so you can't look at, wow, look at ACOs after a year, they haven't saved money. Wrong. That's the wrong timeline. Changing how you actually deliver care takes time. You have to change the office processes. You have to change your electronic health record
and
culture and the data doctors get and how they respond to the data. And that takes time. And we haven't had a big push and given doctors time and resources to sort of, here's how you change an office, here's how you lead, here's how the kind of processes you need to implement. I think that change is going to be really important going forward. We're getting close to a tipping point, but I think we need to move the financial incentives to doctors to 20% for this change, and we need to give more alternative payment models. The private sector and Medicare and Medicaid have to all be pushing in the same direction, and that has yet to really happen.
So, one of the things that's happened, you talk a lot about federal action and the challenges of doing anything in the next year or so. You've got some big players coming in like Walmart, Amazon. You talked about the need for a long time frame. Amazon has a long time frame. What do you think, if anything, about what Amazon and Walmart and other
Well, when you tell me
players
what
are doing?
Amazon is doing, I can respond to it. But so far, lots of announcements and no action, as best as I can tell. I haven't seen the stuff in detail that Walmart is doing. I think we have a very long history of employers thinking, wow, this is simple, I can get in there and, why does it cost so much? Part of the reason it costs so much is you've created some of the problems, employer, because of the way you've structured your benefits. And by the way, your benefits at Walmart are slightly different than your benefits at Best Buy, slightly different from AT&T, and that actually creates a lot of administrative nightmare for the system. One of the things we could do is standardize the benefit packages that all these places have and the arrangements, which, by the way, they do in most other countries. You have to cover these kind of services. Here's the copay structure. Here's the benefit arrangement. That reduces administrative costs on the doctors and the health insurers, and that saves money. And I think a little more push in that direction by the healthcare system, and maybe it has to be regulated or legislated, would be actually quite beneficial. But what's happening in the private sector in terms of the big corporations?
Yeah, I'm thinking less
so
on the...
far, I'm a little. These small corporations,
You sound a little bit skeptical.
Yeah,
just
modestly.
a little bit modest. I think there's a lot of innovation happening, and what we need is some big winners to coalesce. Look, we've had some big breakthroughs in primary care. We've got probably 5, 6, 7 companies that have shown that they can deliver primary care of high quality at a lower price.
Or organizations like...
Well, you've got, whether it's Iora, Care, ChenMed, CareMore, Aledade, Village MD. There's one that someone just introduced me to Cano in Florida. There's a lot of innovation around primary care, and I think we need to push harder and make it easier for those companies to flourish and to really do their wares. I think you've had improvement or some new stuff happening in mental health.
Yeah.
It's a big area. We still need more movement there. We actually need to attract more workers, social workers, psychologists into the field. But that we know is a big winner of big costs. Social determinants, it's been the hot thing for the last 2 or 3 years among companies. We're going to have to push harder on that.
Only an economist would love.
What?
Social determinants.
Well,
Yeah.
I mean,
John,
it's food, it's housing, it's transportation, it's getting people socially engaged. I think those are really important. And I think, again, this combination of stuff that I call, look, when I was training in medical school in the 80s, they were all backwater. We never talked about them, right? We talked about lentiviruses. That was really important to learn. Or the Krebs cycle. That was really important. But that's not where, healthcare is really delivered. These primary care, end-of-life care, mental health care, social determinants, that's where the stuff is happening.
Health or mishealth happens, yeah.
And so, John, last question to you.
I want to know whether we can get the great reveal, because you're coming out with a number of books.
Right.
What country has the best health care?
I will not answer that question. We have 22 metrics on which we
book on it. You can't answer the question.
There's
You
not
gotta buy the book if you want to see the
well,
answer.
first of all, that is true, and even
buy
then,
2
you won't
copies.
get the answer. There are 22 metrics we evaluate, and no country performs well on all of them. Some countries perform well on some, and others. I mean, let me just give you, what do American health patients want? They want doctor choice. Turns out, U.S. isn't so hotsy-totsy. You get much better choice, for example, in Germany or Switzerland or the UK.
No, the dreaded English healthcare system.
First of all, you get choice, unlimited choice, Taiwan, and you get very low payment at the point of care. So the U.S. doesn't excel at that. Long-term care, big sleeper issue that we couldn't seem to address. Germany and the Netherlands have a dedicated financing, tax-based financing for long-term care. No other country has that. And then you
Are
look
we good at anything in the U.S.?
Yes, we are, and I think that, and I actually like to call out. So all this innovation that I see around here, these companies, I don't know what they are, Hint, Village MD, whatever, all these innovations, we are best at innovating. We have an entrepreneurial spirit in this country. We have a broken healthcare system that has lots of openings for innovation, and we have a good ecosystem of venture capital, sales, etc., that allows innovation. We are leading the world in innovation. 2 other areas that I think we're really prominent in. One is innovations around mental health. No country does mental health really well. We are leading in that. We're taking baby steps, but
well, they matter.
Yes, a average heighted person among a bunch of small people, you're still outperforming them. Similarly, in chronic care coordination.
We're sitting down, John.
Chronic care coordination. We know that's important. Yeah. We know that's the future. We've got to do it well.
Are we good at that?
We have a lot of innovative.
Last question is
we
not
have a lot of
innovative.
We have a lot of innovative companies that are primary care groups and insurers that are doing really well. CareMore is a model that's been doing it for a long time. Geisinger has been doing chronic care. A lot of the primary care groups that I mentioned, the way they actually save their money is doing chronic care, identifying the high-risk patients and intervening better. So I would say those are areas where the U.S. is actually performing among the world's best, and I think other countries are looking at us. Bundle payments, another place. Alternative payment models, we're doing better. Other countries are looking at what we're doing, and I think when we get it down pretty well, they will. You'll see a lot of places like with DRGs will come and adopt our payment system.
Awesome.
Well, Dr. Ezekiel Emmanuel, thank you very much for joining us.
That was the longest 12 minutes I've ever seen.
That was a long one. Well, don't worry, the editor will break it down to a solid 11:59. You can watch the entire special series here from the Health Innovation Conference in Las Vegas on your YouTube playlist, or you can listen to wherever you like to listen to your podcast. And most importantly, subscribe to CareTalk so you'll never miss another episode.
Subscribe
and buy my book. Buy my book.
You just got started. Subscribe now. Hey there, listeners. Want more Care Talk? There's more to be had in our other episodes, so be sure to look for those and subscribe to Care Talk on your favorite service.